exists and whether the mode of delivery will actually affect the postpartum cardiac outcomes in these patients. So our objectives were to evaluate pregnancy, delivery, and postpartum cardiovascular outcomes among patients with peripartum cardiomyopathy, and also to compare these outcomes between patients undergoing vaginal delivery versus C-section delivery. The method, so this was a retrospective study. It was with patients with peripartum cardiomyopathy within our health system, which was the Henry Ford Health System. It was defined as heart failure due to left ventricular systolic dysfunction with EF less than 45% occurring either during pregnancy or in the postpartum period. We included patients with peripartum cardiomyopathy diagnosis before delivery, but in that same index pregnancy. And this was classified as cardiac dysfunction at delivery as persistent dysfunction or recovered function, so EF greater than 50. There were some patients that we had to exclude from this study. So we excluded patients that had a different cause of heart failure, whether that was ischemic heart failure, tachycardia-induced, alcoholic, or viral cardiomyopathy. And so our patients were stratified to mode of delivery, so either vaginal or cesarean. And the maternal outcomes were assessed, including ICU level of support, postpartum hemorrhage, length of stay, and then readmission, as well as major cardiac events at 1 year. So we also looked at fetal outcomes, which included admission to the NICU and then the fetal APGAR scores. So we ended up having a cohort of 24 women with known peripartum cardiomyopathy at delivery. Of those 24 women, 13 delivered vaginally and 11 delivered via C-section. And there were 3 operative conversions, meaning those patients were meant to deliver vaginally and intended to deliver vaginally and then got converted to a C-section. No patients in our study required either inotropes or mechanical circulatory support. No patients experienced postpartum hemorrhage, infection, or maternal death. There was 1 VTE that occurred in the vaginal delivery cohort, but there was no observed difference in maternal adverse outcomes between vaginal and cesarean groups. NICU admission did occur in 4 of the cases, but these were evenly split between the vaginal delivery as well as the cesarean delivery. And then at 1 year follow-up, there were no major adverse cardiovascular events that were observed. So most cesarean sections were planned. However, like I mentioned, there were emergent operative conversions that were needed. In these cases, they were for obstetric complications or indications. So moving a little bit into the discussion, with women with peripartum cardiomyopathy at delivery, vaginal delivery was well tolerated when clinically appropriate. The absence of major maternal cardiovascular events suggested that delivery mode alone was not the primary driver of either short-term, intermediate, or even long-term at 1 year follow-up risk. And then cesarean delivery was largely driven by either planned or obstetric indication. So there wasn't clear cardiovascular deterioration that was occurring that would cause this to convert to cesarean. And our findings support a multidisciplinary, individualized approach to delivery planning, meaning if a patient is best for vaginal delivery and that was assessed by all the teams involved, then it's reasonable to undergo vaginal delivery, as it seems that it would be considered safe in this cohort. And continued postpartum cardiology follow-up is very essential for these patients with postpartum cardiomyopathy, as the risk will extend way beyond just the delivery of the patient and even that current hospitalization. So for our conclusions, in this cohort of women with postpartum cardiomyopathy or peripartum cardiomyopathy at delivery, vaginal delivery was not associated with increased maternal adverse outcomes than cesarean. And there were no major adverse cardiovascular events observed either at admission or at 1 year follow-up. But with everyone, delivery planning should really be individualized and should use multiple people. Like I mentioned here, we use cardiology, anesthesia, maternal fetal medicine. So it should be a group approach. And delivery planning is always something that, again, should be individualized. So I have some references at the bottom, but this was our study, and I would just like to thank you for listening and open it up to any questions if there are.
Here is a question for you, Doctor.
Hi,
Yes,
thank
go
you for
ahead.
your talk. Could you give a little bit background of what would be the circumstances that a woman might develop the PPCM during the pregnancy or postpartum, or during the pregnancy of what might be occurring that this would be occurring and then want to be able to monitor during the delivery, or for why you chose to study the delivery of the women?